So this section or this lecture is about the transition from intrauterine life to extrauterine. And it's really important, even though you're not going to see questions about NCLEX that ask specifically about this physiology, it's really important that you understand this physiology in order to know what to do when you're caring for a newborn. So we're going to go system by system, and we're going to begin with the lungs. So in utero, the lungs are collapsed. The fetus does not have a need to breathe because the placenta functions as lungs. The placenta provides for gas exchange. So at birth, the baby has just a few minutes to transition from getting oxygen via the placenta to getting oxygen via the lungs. So the lungs have to inflate, the baby has to begin and maintain consistent breathing, and we have to have gas exchange in the alveoli or between the alveoli and the capillaries. So there are some factors that contribute to that first breath or the initiation of breathing. First of all, there are chemical factors. Remember that we have chemoreceptors in the carotids and the aorta. And when your oxygen level gets low or your carbon dioxide level gets high, those chemoreceptors tell your brain, hey, we need to breathe a little bit deeper and faster. So in labor, we have transient hypoxia. Even the healthiest placenta, there's going to be a little bit of hypoxia. Now, that's one of the reasons that if the placenta is not healthy, it can cause complications for the fetus, because there is some hypoxia involved when the contractions get really firm. When the contractions are really firm, they're not allowing arterial blood flow into the space below the placenta, so they're not allowing that gas exchange temporarily during contractions. So that transient hypoxia in labor triggers the chemoreceptors. And at the very end, when the fetus is actually being delivered, there's not very much gas exchange happening right at that time. And so at birth, that hypoxia triggers the respiratory center in the medulla. Okay. The cord is clamped. Now, there are some prostaglandins that may inhibit taking the first breath. When the cord is clamped, then we might actually be decreasing those prostaglandins. That's kind of a newer piece that's still under investigation. But we do know that in labor, especially at the end of labor, we have some hypoxia, and that stimulates the respiratory center in the medulla. So the baby's born and they're needing oxygen. So the brain is saying, breathe. There also are some mechanical factors. During a vaginal birth, the chest is compressed as it goes through the vaginal canal. And then as it exits the vaginal canal, that compression is released and there's some rebound. That rebound creates negative intrathoracic pressure at the same time that hopefully we're getting external stimulus that's startling and some hypoxia. So that hopefully is coinciding, that rebound and negative pressure is hopefully coinciding with first breaths. So we've got air going in and negative pressure pulling and hopefully helping to promote lung expansion. After the first breath, each breath continues to open more alveoli. Crying helps to distribute the air evenly through the lungs. Now, some babies don't cry at birth. That's generally okay. It just takes a little bit longer to get air distributed throughout the entire lung. Most babies are going to cry at birth, and that pressure, that glottic pressure actually increases or distributes the air evenly. Now, there are some thermal and sensory factors. The baby is born from an environment that's around 98 degrees, between 98 and 99, goes into an environment that's around 70 degrees. So that change in temperature causes a gasp. We also go from, the baby also goes from a warm, dark place where they can see light through the abdominal wall, but it's very a dull reddish light. They have been floating in water, so what's touching them is fluid, and so then they're handled. So they come out into this light, bright, cold world, and those changes also can stimulate that initial gasp. So hopefully, if everything works together, we have decreased oxygen, we have increased stimulation, we have a drop in temperature, and all of those will cause the baby to gasp. And at the same time, the squeeze and release, the thorax is squeezed through the vagina, and when it's released, that negative pressure helps with the expansion of the lungs. And then they continue to take more breaths and open more alveoli and distribute that air more evenly. So there are some physiologic changes that happen leading up to delivery and then after delivery. So in utero, in the last few days of pregnancy, the fluid that is in the lungs actually decreases. Remember that it's not the same as amniotic fluid, it's lung fluid. It's a very specific fluid. And that production decreases in the last few days of pregnancy. When the lungs expand, that lung fluid is pushed to the periphery of the lung. They don't have to cough it all out. You will have some mucus and fluid coming up, but you also will have a lot of the lung fluid is pushed to the periphery of the lungs as the lungs expand and filled with air, and it's absorbed into the lymphatic system. There is something called transient tachypnea of the newborn when that lung fluid takes longer to absorb, and that baby will be tachypneic. The respiratory rate will be higher than it should be. They may have some crackles. It's more common in babies that are a little bit preterm or babies born by C-section, especially if there's no labor. Remember surfactant. So the alveoli are collapsed, and when they take that breath, it's a lot of work to expand the alveoli because the fluid that's in the alveoli wants to, the surface tension wants to keep it collapsed. So we have surfactant, and the surfactant in those alveoli decreases the surface tension, so it's easier to get air in. So if there's not enough surfactant, then those alveoli keep collapsing and the baby keeps having to work to open them back up, okay? So the surfactant decreases the surface tension inside the alveoli and allows them to expand more easily and to remain expanded. In utero, the fetus has breathing movements intermittently. Closer to birth, they become more frequent and more regular, but those breathing movements have to be consistent after birth. Infants, newborns usually show abdominal breathing. Their breath sounds are clear and loud when you listen to them with a stethoscope. Respiratory rate should be between 30 and 60 respirations per minute at rest. If they're crying, it's going to be higher than that at times. They have shallow, irregular, periodic breathing. So you always need to count respirations for a full minute. Pauses should be less than 20 seconds. If they have pauses that are longer than 20 seconds, and that's considered apnea. Newborns are nose breathers, so it's very difficult for them to breathe through the mouth. So if their noses are clogged or obstructed, they cannot breathe. Some signs of respiratory distress, and these you need to know. In a newborn, what does it look like when they're struggling to breathe? They may have nasal flaring. Remember, they're nose breathers, and so their nares will flare trying to get more air in, like, okay, nasal flaring. Intercostal or subcostal retractions. You've seen retractions in older patients. If they're working really hard to breathe, they're using the intercostal muscles, and so the tissue in between their ribs sucks in. They may actually have retractions, like abdominal retractions under where they're just working so hard. Grunting. Grunting is this is a sound that you don't always hear with adults who are having dyspnea, but you can hear it with babies. they're working, it's a little extra push to get the air out so that they can breathe in. And it's kind of hard sometimes to distinguish, are they grunting or are they fussing? But it's just a little sound that happens with each breath, okay? Seesaw respirations, they're really struggling when their chest and their abdomen are moving opposite each other. They're working as hard as they can possibly work. A respiratory rate less than 30 or greater than 60 at rest, and central cyanosis. Now, it is normal for newborns to have some cyanosis of the hands and feet that comes and goes in the first few days. It's called acrocyanosis, and it has to do with the change in those circulatory pathways that we're going to talk about in a few minutes. But if they're cyanotic in the face or trunk, that's a problem, and that's a sign of respiratory distress or cardiac issue. Okay, so that's respiratory changes. The next section, we're going to talk about cardiovascular changes, and this is where you're going to need to remember what fetal circulation looks like.